Good morning. I'd like to thank the organizers again for the opportunity to present on the subject of ventilator-induced diaphragm dysfunction and myotrauma. I have no conflicts of interest to report. So we have a vocabulary in critical care medicine around ventilator-associated iatrogenesis. For probably 30 to 40 years, we've been talking about ventilator-induced lung injury. We have barotrauma, we have volutrauma, we have atellect trauma. And these words are very helpful to us in sort of discussing at the bedside the kinds of mechanisms, our clinical concerns, and they sort of guide our treatment and therapy. And together they've led to the concept of lung protective ventilation, which has proved to be an effective means of improving clinical outcome. Well, I want to introduce into our parlance this morning two additional terms related to ventilator-induced diaphragm dysfunction. And those terms are myotrauma and muscle protective ventilation. And over the next 15 minutes, I want to convince you that these are useful terms, they're relevant and appropriate, and I'm going to present some novel data to support the clinical significance of myotrauma in our patient population. I should say that none of this data has been published yet, so I ask you not to record it or post it, but hopefully will be in print in short order. So obviously when we speak about myotrauma, we're talking about a causal inference that mechanical ventilation is actually causing diaphragm injury and dysfunction, and in turn potentially affecting the patient's clinical outcome. So assessing causality is challenging at the best of times, and we have a number of tentative criteria that have been offered about how we can assess whether a cause and effect relationship is truly at play. And things like temporality, the idea the cause has to precede the effect, consistency of the relationship between purported cause and effect, the biological plausibility in terms of putative mechanism, and finally biological gradient, which is really the idea of a dose-response relationship. So when all these things are in place, our confidence that a true cause and effect relationship grows, although it's not necessarily definitive. So in terms of consistency, there's no question that we've observed very clear, consistent effect of mechanical ventilation on the diaphragm. And this is, we now have a large and substantial body of literature on the deleterious effects of mechanical ventilation in animals. And Professor DeMuhl has already done a very nice job of outlining that. But basically, the cardinal features that are observed across different animal models are contractile dysfunction, atrophy, resulting from oxidative stress, mitochondrial dysfunction, activation of various proteolytic systems, and autophagy. So really a striking consistency, I think, across animal models. And many of these same features have been demonstrated in the few studies that exist in humans, most of which have been done in brain-dead organ donors, although we now have the very exciting data from Con Ottenheim's group showing that in live mechanically ventilated patients there is indeed contractile dysfunction, atrophy related to activation of the ubiquitin proteasome system, and again, the same mitochondrial abnormalities and oxidative stress. The missing piece, of course, in humans is that we haven't been able to take a human and apply complete diaphragm inactivity experimentally and see whether or not that generates the cardinal features. But the downstream effects are consistently observed in humans as well. In terms of plausible mechanism, there's a number of potential mechanisms by which ventilation might injure the diaphragm. Disuse atrophy is, of course, the one that's been discussed the most. So if you take a rat and you anesthetize it, but keeping it spontaneously breathing for 24 hours, you really see no change whatsoever in the force frequency curve of the diaphragm. Whereas if you take rats, apply controlled ventilation, completely ablate any diaphragm activity, you see a progressive decrement in force generating capacity over the 24 hours. So there's no question that pure disuse, as we've talked about, can cause diaphragm dysfunction. So one plausible mechanism. A second plausible mechanism of diaphragm injury during mechanical ventilation is actually the exact opposite. And it's possible that under-assist related to inadequate ventilatory support could also contribute to diaphragm dysfunction. These are interesting data in humans done by a group over 10 years ago where they took healthy subjects who were going for some elective surgery and patients with COPD who were also going for elective surgery. And they applied an inspiratory loading task for approximately half an hour, and showed that both in the healthy subjects and in the COPD subjects, just that brief excess loading task could induce significant sarcomeric disruption and evidence of diaphragm injury based on biopsies they collected at the time of surgery. So even excess loading of the diaphragm related to under assist during mechanical ventilation could also mediate diaphragm injury. And then this came up briefly as well yesterday, the role of eccentric contractions of the diaphragm. So we often speak about concentric contractions where the muscle is generating force as it shortens, and that's the usual type of contraction we see in such a case. The diaphragm dome would be descending. But if the diaphragm is actually lengthening while it's generating force, in which case the diaphragm dome would be ascending, that type of contraction is much more injurious. So for example, when you go to the gym and you're lifting weights to work out, you want to generate eccentric contractions because those are the ones that really train the muscle, and the way they do that is by causing significant muscular injury. It's also the reason why you're so sore the day after skiing. And just to show that eccentric contractions are an important issue with respect to the diaphragm, these data here were obtained by a group that took dogs, casted the abdomen to elevate the diaphragm, applied magnetic twitch stimulation, and so here's the first twitch before the casting. After the casting, the stimulation pressure goes way up, and that's of course because you've got a greater mechanical advantage now that the diaphragm's been elevated. But the subsequent stimulation saw a rapid and quite dramatic decrement in force that persisted for this period of time, which was, I believe, about 10 minutes when they kept the animals casted. And then they continued twitching for another 12 hours and showed that this injury and dysfunction persisted for that whole period of time. So even in a brief period of significant eccentric contractions could be injurious. And as discussed yesterday, those potentially are happening during ineffective efforts or wasted effort dysynchrony during mechanical ventilation. So in animal models, we've got clear evidence that disuse or overload can lead to diaphragm injury and dysfunction. What's missing is the human data about biological gradient. That idea that the degree of injury and dysfunction that's observed is proportional to the degree of disuse or overload. And so I want to present some data from some of the ultrasound studies that we've been doing that tries to address the question of biological gradient. So as I mentioned yesterday, with bedside ultrasound, you can ascertain the thickness of the diaphragm in the zone of apposition, and you can also measure inspiratory effort, or at least estimate it, based on the degree of thickening that's observed during the respiratory cycle. And we recently published our work showing that these measurements can be made, this measurement of thickness can be made with excellent precision, the measurement of thickening fraction with moderately acceptable precision. It's been previously shown that the degree of thickening here is nicely correlated with inspiratory effort during mechanical ventilation. So in terms of biological gradient, we now have data suggesting that inactivity or underactivity is very common during mechanical ventilation, and Dr. Mario's data really showed that very nicely. We obtained similar results in our ultrasound study, where we found that compared to healthy subjects at rest with a typical diaphragm thickening fraction of between 25 to 40%, patients on both partially assisted and controlled ventilation tended to have much lower levels of thickening fraction. Patients who are on neuromuscular blockade typically showed almost no thickening, and that just reflects the fact that there's a tiny contribution from expansion of the chest to the measurement of thickening fraction. But so there's clear evidence that disuse or inactivity is common during mechanical ventilation. In data that we haven't yet published, we conducted an ultrasound study measuring diaphragm thickness on a daily basis for the first 14 days of mechanical ventilation. We enrolled over 100 patients and collected over 500 patient days worth of data. And what we found is that many, but not all patients developed dramatic decreases in diaphragm thickness over time. We were able to divide the patients up into 3 different groups: those with more than 10% loss of thickness, those with no significant change, and those with a more than 10% increase. And what you'll see is that about 45% of the patients lost more than 10% of their diaphragm, some considerably more, in the range of 30 to 40% in just the first 3 to 4 days of mechanical ventilation. On the other hand, many patients had no significant change, and to our surprise, a number of patients actually had a significant increase in their diaphragm thickness. So the question then, of course, is what is determining this difference between the patients who are losing thickness, the patients who were having unchanged thickness, and the thickness increasing? And when we designed this study, our a priori hypothesis was that the level of diaphragm inspiratory effort measured by the thickening fraction would be an important determinant of that change. And that is indeed what we found. So let me just explain this figure here. So on the z-axis, you've got diaphragm thickness as a percentage of baseline. So everybody starts here at 100%. You have on the x-axis here the duration of ventilation or time. So really what we're looking at here is the change in thickness over time. And then on the y-axis, you've got diaphragm contractile activity measured by the thickening fraction. And so this is the results of the statistical model that we computed from our data, showing that at extremely low levels of diaphragm contractile activity, the rate of atrophy over the first 7 days is approximately 4% per day. Whereas in patients with very high levels of activity, the thickness of the diaphragm actually increased. So these data suggest that the level of inspiratory effort during mechanical ventilation is a key determinant of whether the diaphragm thickness decreases or increases. And what was particularly striking to us was that inspiratory effort level that was consistent with no significant change in diaphragm thickness is actually the normal level of inspiratory effort we observe in healthy volunteers. And we corroborated this, which was really our primary analysis, multiple other approaches trying to assess the relationship between effort and change in thickness. Now, the question, of course, is what determines a patient's inspiratory effort level during mechanical ventilation? And we showed that we found that driving pressure was a weak but significant determinant of diaphragm activity, so that here you've got the mean driving pressure over the first 72 hours and the mean change in thickness over the first the mean thickening fraction over the first 72 hours. And patients with higher driving pressures tended to have lower levels of activity, but of course there's a huge amount of overlap here at all levels, really suggesting that you cannot predict a patient's inspiratory effort level purely from their ventilation settings, which of course makes sense physiologically. The other thing that's quite interesting is that this is the average driving pressure in the 3 different groups of diaphragm thickness change. So on the y-axis here, you've got the average driving pressure over the first 72 hours. These are the patients with more than 10% loss of diaphragm thickness before day 8. These are the patients with no significant change, and these are the patients with an increase. And what you see is that, again, while there's significant overlap, there is a statistically significant relationship between average driving pressure and the change in diaphragm thickness, again suggesting that the way we're ventilating the patient might actually be an important determinant. And finally, what again was very striking to us, we measured in a subset of these patients, 20 of them, we measured diaphragm function using the maximal diaphragm thickening fraction obtained during a maximal inspiratory effort. And what we found was that patients with both decreases and increases in diaphragm thickness tended to have reduced diaphragm function compared to patients with no change. And this was quite surprising. I was expecting something of a training effect where the patients with a gain in thickness would have a higher level of function, but that's not what our results bore out at all. And a previously published cutoff for severe diaphragm dysfunction based on maximal thickening fraction of 20% showed that a significant proportion of the patients with loss or gain had severe diaphragm dysfunction, whereas only one of the patients in the near baseline. And again, these groups were statistically significant lower than some of the control subjects. So these data, they're not randomized trial data. They don't definitively prove causality, but they provide strong support for a biological gradient between the excess ventilatory support or inadequate ventilatory support and the development of diaphragm injury and dysfunction. And for this phenomenon, which we already referred to as ventilator-induced diaphragm dysfunction, I'm proposing the term myotrauma. And this leads us really to the question, as already discussed this morning, whether we could develop muscle protective ventilation strategies to prevent diaphragm injury and dysfunction and potentially improve the outcomes of our patient. Thank you very much.
Thank you, Ewan, for your great talk. We have time for one question.
Good morning, and thanks for this great talk and these wonderful data. How can you be sure that when you see an increase in diaphragm thickness, that it's functioning muscle and not just edema in a septic patient?
That's a great question. In fact, that's one of the things I suspect is a cause of an increase in thickness over time. I didn't have time to present it, but in our model, the only other important determinant of change in thickness over time was the SOFA score. And the higher the SOFA score, the more likely the thickness was to increase over time. So I suspect that patients who have more systemic inflammation are more prone to developing overload injury or muscle edema. But because we don't have tissue, which we'd love to have, but it's just so difficult to get in these live human subjects, I can't answer your question. But I think that's a really important hypothesis.
Thank you very much, Ewan.